You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 1st, 2025. Our topic today is Dermatology for the Allergist. This is presented by Dr. Mark Serota from Peak Dermatology in Littleton, Colorado.
Allergy fellowship at Children's Mercy, finished in 2012, fully intended on just being an allergist. And when I was doing my fellowship, I realized we were seeing a lot of dermatology, and I didn't really know what I wanted to know about dermatology. I ended up doing a rotation in dermatology as an elective, and really fell in love with the specialty and really the overlap between the specialties, and ended up deciding to do a second residency in dermatology after my allergy fellowship. So the first thing I did after I took my derm boards was I went home and I created a talk called Dermatology for the Allergist, which ended up being about 90 minutes when I realized how much stuff I put into it. And I cut that down to about 45 minutes, which is the talk I'm going to give you today. But the goal was to know what you don't know. So I know that you know a lot about eczema. I know you know a lot about urticaria and allergic contact and all those things. But when you walk in the room, first of all, how are you going to evaluate and describe a rash? And what are the mimics of the things that you're going to see commonly that you should know and be thinking about when you see an eczema patient, when you see a hive patient, when you see an allergic contact patient? What are the things that are in the differentials that you should be thinking about, so that when it doesn't really fit the typical bread and butter eczema patient, you can say, all right, here are some of the other things I should have thought about that maybe I need to go back and decide if I'm missing any of those things. So that's the goal for this talk, is to take something that I think is an area of medicine where you don't get a lot of training necessarily in med school, and turn it into something that is accessible, and you could think about how you're going to treat a patient in terms of the differential diagnoses and things that you should be running through in your mind when you see a rash patient. So here's my disclosures. I'm not really going to talk too much about treatments today. It's mainly going to just be diagnoses and a lot of photos and a lot of kind of superficial things. So we're not going to dive into too much detail into any one particular diagnosis. And I would love to give an hour talk on eczema or CSU or one of these things, or any of the mimics of the things we talked about today, but this is going to be more of a mile wide and an inch deep. So we're going to try to cover a broad selection of the most common dermatologic issues that you might come across in your practice as an allergist. So if you're not going to see it as an allergist, I'm not going to waste time, talking to you about it, because you're never going to see it. But the things that mimic the things you see in the allergy office are things we're going to focus on. So we're going to focus on diseases related to atopic dermatitis. That doesn't mean mimics. That means adjacent diseases, where if they have eczema, they could also have these other skin issues. We're going to look at mimics of allergic disease, and then we're going to focus on some diseases not to be missed. There's not that many, derm emergencies. I could probably count them on less than one hand. But things that if it walks into the office, you want to make sure you get it right the first time, because it can significantly impact someone's morbidity, or in a worst case, their mortality even. So we're going to go over ways to describe skin findings. We're going to discuss some commonly encountered skin conditions focusing on mimics, and we're going to try to understand different dermatologic treatment options and diagnostic modalities. So when I highlight the disease, I'll try to give you, here's how I'd handle this disease. So at least you have some familiarity in your mind, and then you can still go back and look it up on UpToDate or whatever other resource you like to use later. We're not going to focus on these things. I love these things. I'd be happy to give a lecture on any one of these things, but we're not going to do that for today, because I know you know a lot about these. You could probably give me a lecture on some of these things. So here's the tools of the trade in dermatology. So at the top, you have your dermatoscope, where you can look at things with much closer magnification. You have a punch biopsy, shave biopsy. You have a skin scraping that you can do with a 15 blade there on the bottom left. And then on the bottom right here is called dioscopy, where you can press a microscope slide against something and see if it blanches, which sometimes can be helpful. And I would advocate for the biopsies right here. I think every allergist should know how to do a skin biopsy. If you don't want to learn how to do a punch biopsy because you don't want to deal with suturing things, just do a shave biopsy. This is good for 95% of the things you're going to see in allergy anyway. It takes about 60 seconds total to do. All you have to do is know how to inject a subcutaneous injection of 0.1 cc's of lidocaine and take a little surgical blade and just shave off a little piece of skin. We teach that at the American College of Allergy, American Academy of Allergy. There are biopsy workshops. I used to lead them. When I go to those meetings, I still do, but I don't travel as much as I used to. But I highly advocate for them. They're the one thing I've ever seen where everybody rates them as 5 out of 5 stars across the board. Like you literally just get all 5s. It's like the highest rated thing. It sells out almost immediately. You have to pay for it, and it'll add a ton of value back to your practice. So I'll put in a plug for that. The other thing I'll put in a plug for, just since I'm talking to a group of allergy fellows, is I highly advocate that everybody should want to do some public speaking and do lectures like this. It gives back to the specialty. It gives back to how you got trained and kind of paying it forward, but it also raises your profile quite a bit nationally. I get invited to do national lectures at the American Academy, American College, lots of derm meetings and things like that. Yes, because I have a background in both of those specialties, but also because I enjoy public speaking. You develop somewhat of a skill for it, and you develop a niche of things that you have an expertise in that people want to hear you talk about. And it's an ancillary stream of revenue as well. So it's good all the way around. But in the beginning, it raises your profile where you become nationally known for things, and a lot of opportunities open up. So if you're someone that doesn't like public speaking, it just takes doing it over and over again, and you get really used to it, especially if it's a topic that you like talking about. So I always try to plug that when I talk to allergy fellows. So biopsies, public speaking. Okay, so dermatology, one of my mentors in derm told me it breaks down to 2 things: growths and rashes. And you don't have to deal with growths because you're in the allergy world, so you're not going to see skin cancer type stuff. So I already eliminated half the specialty for you, so let's make it easy. But before I totally eliminate it, let's save someone's life. So here's one slide on growths. We talk about the ABCs: asymmetry, irregular borders, multiple different colors. D is diameter greater than 6 millimeter, which is about pencil eraser size, or if something's growing or changing over time, so evolution, A, B, C, D, E. If it is violating these rules, or if it's just an ugly duckling, it looks like nothing else on their body, it's bleeding, it's growing, it's painful, send that to a dermatologist immediately. You could save somebody's life. Remember these things for melanoma. That's what kills people. And if you think this is pie in the sky, I gave this talk to the Colorado Allergy Society, and then a week later, one of the allergists there sent me this lady. She had this lesion near her eye. It turned out to be a melanoma. We biopsied it. It was still superficial. It had not spread yet, and she was able to just do fine with an excision and go on with her life. Had they not picked that up, and maybe she waited another year before her next checkup with somebody, this could have been a very different outcome. So pay attention when you're looking at someone's skin. Just because it's not your specialty, do you see something like that that's concerning to you, don't be afraid to just send it to the dermatologist. Okay, so how do we describe skin lesions? It breaks down to primary and secondary. I call primary the noun and secondary the adjective that describes the noun. So these are the common nouns, things like macule, patch, papule, plaque. We'll go over what these mean. And then secondary is basically, how am I going to describe the noun? So is it fissured? Is it excoriated? Is it thickened and lichenified? Is it crusted? Is it scaly? So you're describing the noun. So a macule is simply a flat change in the skin. It's less than 1 centimeter, and you cannot feel it. So if you closed your eyes, you wouldn't feel it. So something like a freckle or a sunspot would be an example of a macule. Contrasting with a patch, which is the exact same thing as a macule, except it's greater than 1 centimeter. So something like a cafe au lait spot or a patch of vitiligo. But if you closed your eyes, it would not have texture. It is flat. Papule is the inverse of a macule, so it's less than 1 centimeter, but it's raised. So here's an example of some molluscum papules. So flesh-colored, so we would just describe it, flesh-colored papule. Maybe you would note the central umbilication here, so a little dimple depression in them. Something like acne or molluscum would be examples of papules. Contrast that with a plaque, which you're going to see a lot in your world, which is the equivalent of a papule, except it's more flat-topped, and it's usually greater than 1 centimeter. So examples of this would be a plaque of psoriasis or a plaque of eczema, and you could expand on that by saying erythematous, which just means red, maybe excoriated, crusted plaque on the antecubital fossa. If I said erythematous, excoriated, crusted plaque on the or scaly plaque on the antecubital fossa of a 7-year-old, I wouldn't have to show you a picture or tell you anything else. You would know that that's eczema, right? Or if I said it's on the extensor surface of the elbow and it was a salmon-colored erythematous plaque with white silvery scale, I wouldn't have to show you a picture. I wouldn't have to give you anything else. You would know that that's psoriasis. So by using some of these descriptive terms, you can sort of paint the picture for somebody verbally what is going on and what it actually looks like. And if you take pictures, that's always great. Vesicles are kind of like a papule, except they're not just raised. They're not just less than 1 centimeter. They're also fluid filled. And a great example of that would be HSV. So we might say these are a collection of grouped yellow or yellowish vesicles on a base of erythema clustered on the lower lip or something, or the flank. And that would be describing HSV. Here's bullae or bulla. So this is greater than 1 centimeter. They can be tense or flaccid. This would be a tense bulla. Flaccid would be where they're kind of drained out, where they're not filled up and tense like this anymore. So this is an example of bullous pemphigoid, an immunobullous skin disease. And then pustules are kind of similar to vesicles, except they're not fluid filled with clear yellowish fluid. They contain specifically pus, and we call them pustules. So that could be from an infection. It could also be from inflammatory skin conditions like pustular psoriasis, which is the example shown here, where you'd say a collection of grouped yellow pustules on a base of erythema distributed in the following distribution. And that would be an example of pustules. And there are medication reactions like AGEP, right? Generalized pustulosis from things like medications that can also result in pustules. So when you see pustules, that means pus. Pus doesn't always mean infection. So it could be sterile pustules. And then the secondary lesions, I'm not going to go into all these in detail, show you pictures of these. You can imagine some of these are kind of self-explanatory. Lichenified means thickened, usually from rubbing or scratching. You can have erosions where you've removed the superficial layers of the skin. You can have linear fissures. You can have ulcerations, which means it goes down all the way to the dermal layers, etc., etc. You can also have patterns of rashes. So, for example, annular means circular, like an annular rash. So we'll show you some examples of those. There's dermatomal distributions. There's clustered, I just talked about. There's also blascoid, which if you don't know what that is, I'll show you. There's also something called Kebnerized, which I'll show you. So there's different patterns of rashes. Guttate means teardrop shaped, for example. Follicular means it goes along where the hair follicles are. Like if you have little pustules that are where the follicles are, it could be an example of a folliculitis, for example. So there's different patterns of distribution. For the sake of this talk, I'm not going to show you all these in great detail because I could do that for the next 30 minutes. But it's important that you understand that these are the different ways in which you could describe rashes, and the individual lesions, the adjectives, and then the pattern that rash is following. And I encourage you to look in some reference text to see, what these differences are and how that can go into a differential diagnosis. But I'll highlight some that you may see. So one's called the Kebner phenomenon. So this is kind of the equivalent of dermatographism for an inflammatory rash. So hives, you can stroke someone's back and you can write your name on their back in hives. That's dermatographism. Kebnerization, named after Dr. Kebner, who described this phenomenon, is where you can create an excoriation on the skin or trauma to the skin, like a surgical incision. And if the person has, for example, psoriasis, you could see that they develop psoriasis in this external pattern. This isn't something that your body makes internally. This is something that came from external scratching, but it's not dermatographism, it's psoriasis. You can have dermatomal distributions. So this is where it follows along the roots of nerves. So as the nerve traverses out of the spine and travels along to its ultimate destinations, you can get a dermatomal distribution. If you see a rash or any other skin complaint in a dermatomal distribution, you should be asking yourself what's going on with the nerve underneath. Is this about to develop into zoster? Is there a tumor or some lesion pushing on the nerve in that location, and that's why the person is itchy and scratching only in that location? Anything that's dermatomal, ask yourself what's happening with the nerve underneath, and am I seeing it yet, or is the nerve getting tickled but it's not actually developing into something visual yet? Either way, what's going on with the nerve underneath? Blaschko's lines or Blaschkoid distribution traces the embryonic development of stem cells. It looks a bit different than just tracing nerves because this is how stem cells migrate. So it's a more world look, especially over the back where it's more V-shaped here, or over the chest where it's a little more like S-shaped. So it's not really dermatomal, but sometimes you can see diseases that follow along this pattern. And the classic example of a Blaschkoid distribution is lichen striatus in a child. This is a self-limited pediatric disorder of the skin where you see this inflammatory Blaschkoid distribution in the classic areas over the arm, forearm, and onto the hand. And if you didn't know that this existed, you would say, maybe this is allergic contact, maybe this is zoster, this is some sort of dermatomal thing. You say, no, wait, this is a kid, this is actually a Blaschkoid distribution. All I have to do is give reassurance to this parent, or maybe some topical steroid if it's mildly itchy, and know this is going to go away as the child grows up. So Blaschkoid distribution, maybe you're less familiar with. Okay, so let's get in now to atopic dermatitis, especially some atopic dermatitis adjacent diseases. Before I do that, let's just give a word on atopic dermatitis. Number one, it's the itch that rashes. It can be anywhere on the body. It's easy when it's the folds, the elbows, the folds of the knees, the cheeks of a child. I care much more that you know you're in the eczematous dermatitis pathway. So if you know that looks like eczema to you, if it's not in the fold, but it's on some weird location that is not classic eczema, that's fine. It can be anywhere on the body. So start with, do I think this is an eczematous dermatitis, or do I think it's a mimic, or I'm not sure? If you think it's an eczematous dermatitis, or if you're not sure, start asking about comorbidities. Do they also see you for rhinitis or for asthma? Do they have a family history of atopy? If yes, that's more suggestive that it's eczema. If no, start asking yourself, did they have any other things that make me think that it might be something else? Is it actually on the elbows and the knees and it's more like a psoriasis rash? You know, is it fitting an atypical pattern, like the person's 60 and they've never had eczema before? Maybe there's a medicine they're taking that's not playing well in the sandbox that's causing a rash. So think about, does that look eczematous? Yes, no, maybe. If yes, treat like atopic derm. If no, look for mimics, consider biopsy. If maybe, start looking for history points to help you one way or the other. Here's the classic areas for a child. So again, if it's classic eczema, you just treat it and look for comorbidities. And these are the classic areas that can help you. So here's some eczema adjacent diseases. A lot of patients with eczema also have or develop allergic contact dermatitis. That will still look eczematous to you, but it will be in a geometric, outside the body type distribution. History is everything. When you patch test, you want to patch test for the common things plus any daily use items. So ideally, if you can do the North American standard with thin chambers, so instead of just doing a true test, you can actually test their own personal products. That way you can say, hey, you're allergic to propylene glycol, and you also reacted to the moisturizer that you gave me that has propylene glycol in it, so clearly there's a correlation there. Or, hey, you didn't test for anything positive on my patch testing, but you clearly are testing positive for the moisturizer you provided me, so it must be an ingredient in there we didn't test for, but either way, this is what your moisturizer does to your skin. That's also helpful. So you should try to do some use testing, and if you're not using the fin chambers, just do a use test by putting a little dab on the forearm, put like a Band-Aid or something over it, and then let it sit there for 48 hours and see if they're common use items they use a lot, see if that's making them break out, and then that way at least you can help correlate some daily use items if you can't give them the actual ingredient that they're allergic to. And this is a patient I consulted for in the hospital. She was admitted for an infection. She's clearly pregnant here, and she had an amniocentesis, I think, on her belly, and then she developed this rash, and they admitted her for vancomycin and like pretty heavy duty antibiotics and hospital admission and everything. And I went up there, I was like, guys, like this is clearly where the adhesive bandage was after the procedure. These things can get pretty angry looking. They can even look like yellowish and pus and stuff, but this is just a rigorous allergic contact. Like, stop the vancomycin and give her clobetasol and send her home. And they were like, no, Mark, we're going to leave her in here for a week for vancomycin. And I was like, well, okay, but she's going to be better in 2 days with clobetasol. And she was, and then they believed me and sent her home. So if you biopsy that, or if you biopsy this, or if you biopsy anything else that's eczematous dermatitis, you're going to get the exact same biopsy picture, which is, this is normal skin where you see this nice basket weave of epidermis. We call it basket weave orthokeratosis because there's no nuclei in here. So your skin cells go up through the different layers of your skin, and I won't ask you to go back to med school and remember the basal layer and the layers above that, but they push their nuclei out, and you get this basket weave orthokeratosis and these nice tight junctions here without any space in between. When you get eczema, You don't get basket weave orthokeratosis up here. You get the nuclei that are actually in the epidermis up here, which isn't really shown in this slide. But what you see here is this ballooning out of the lower epidermis, and that's called spongiosis. So you're going to get a biopsy that looks like spongiotic dermatitis with some eosinophils, some of the bright red cells, inflammatory cells in here. That's spongiotic dermatitis. So if you biopsy atopic derm or allergic contact or nummular or irritant or any of these things, you're just going to get this standard smart text reading from the pathologist that says sponge derm. You know, they're just going to type /sponge derm, and it's going to just put in a description of this right here. Now, if you're biopsying because you're not sure if you're in the dermatitis category, you think you might be a psoriasis patient or a CTCL patient or, you know, a lichen planus patient or something else, then you biopsy it because it's worthwhile to differentiate a dermatitis versus a not dermatitis. Your biopsy is not going to tell you if it's allergic contact or atopic or nummular or any of those things. So here's some diseases associated with eczema. So here is some flesh-colored umbilicated papules that are on an erythematous eczematous base and located in the antecubital fossa. I already showed you this when we talked about the morphology. And this is molluscum contagiosum. You can get molluscum dermatitis with it. So it's a chicken or the egg thing. You know, did the skin barrier dysfunction cause the molluscum to be able to propagate there? Or did the molluscum propagating there cause a dermatitis and just irritant reaction? I think probably a little more that the skin barrier is broken down, and that's why it likes the antecubital fossa, just like eczema herpeticum would do. But regardless, the point here is you need to treat the eczema to repair the skin barrier, but you also need to do something to treat the molluscum. Here's an example of molluscum dermatitis where these are kind of scabbed over and more serum, we call it serum crusted instead of using the word scab, serum crusted molluscum papules. And the treatment, you can do intralesional candida, which is my favorite. So you take the candida that you guys normally use for allergy testing. It's a 1 to 1,000 dilution, so the intradermal dilution, and you inject it into the candida. It stimulates the immune system to go there and sample the candida. It also targets the molluscum at the same time, and it works like magic. After 3 or 4 injections, the molluscum is gone. You can also do destructive things if you're a little more sadistic. You can freeze them. You can curette them, although that's terrible because now you're causing scarring for the kid. You can use an imiquimod cream, which is a toll-like receptor 7 agonist. Why do I highlight that? Because board exams love it. They love all the TLRs. It's been like a decade since I looked at board fodder, but I'm guessing that's going to be on your test. So imiquimod cream agonizes TLR7, but my favorite's the intralesional candida. Also similar, another viral thing that eczema patients can get is eczema herpeticum. You want to always notice when things are clustered or punched out looking like this. This is on an erythematous base again, but you see these yellowish, punched out, crusted papules that are coalesced into these larger plaques on the face of an eczema patient. And I'm using the descriptive terminology over and over so you kind of get familiar with the lingo here. But this is eczema herpeticum. And the idea is you want to treat aggressive with systemic therapies like acyclovir, valacyclovir. These patients are miserable. You don't want it going to bad places like the eyes or the brain or the CSF. You want to treat it and kill it in the crib with acyclovir or valacyclovir. This might require some hospitalization and IV antivirals initially. And you can always unroof and scrape a lesion, send it for immunofluorescence or reflex culture if it's negative, and you'll identify the virus to confirm your diagnosis. As a dermatologist, you could look at that and just go, that's eczema herpeticum. We'll swab it just to make ourselves feel good, but we're starting antivirals on this kid. Contrast that. So these are not punched out. They're not really clustered, like punched out individual looking circles like this. This is more diffuse, more honey crusted. It is in a distribution that also coincides with their eczema. And the tip-off here is the yellowish honey-crusted appearance. Hopefully you can appreciate that. And that's impetigo. This is a bacterial infection superimposed on eczema, whereas the punched-out, circular, quite painful lesions I showed you previously were the eczema herpeticum. This is a little more diffuse, a little bit less. It's not going to be particularly painful. They could have low-grade fevers with it. There's still going to be a base of erythema. And you see these little satellite things here, like these little isolated bacterial colonies. So this you're going to treat with antibiotics, of course. And you can also get flaccid bulla, where you get these yellowish bullae that can also be impetigo, where it's actually yellow bulla, like they're like flaccid, not tensed up like what I showed you before, but kind of loose looking. That can also be impetigo. Usually it's S. aureus. It could also be group A beta hemolytic strep. Most of the time it's going to be Staph aureus, but if it is strep and you're going to culture it to figure out the difference, post-strep glomerular nephritis is more common with this than it is with strep pharyngitis, which means you want to check how their kidneys are doing now and then a month later so that you don't miss that that actually affected their kidneys. And you're going to treat them with antibiotics. Okay, another eczema adjacent thing. You're going to see this if you haven't already in your practice, and if you misdiagnose this as vitiligo or fungal infection or something like that, you're not going to after this. This is a kid. They have dry patches of eczema on their face, and then they have these hypo but not depigmented patches. So it's a patch, so it's flat, it's not crusty. It's hypopigmented, meaning there's some pigment here, but it's not depigmented like you would see with vitiligo. And this, most importantly, it's on the face of this kid or the upper arms of this kid, and they also have eczema. So this is called pityriasis alba. Alba in Latin means white. More common in atopic patients, more obvious in darker skinned patients. It's flat, it's not scaly. And if you scrape it with that scalpel blade like I showed you before, you just scrape, perpendicular to the skin, put it on a microscope slide and put some KOH on there looking for fungus, you're not going to see it. I don't usually do that in these kids because this just looks like P. alba to me. But if you weren't sure, you could, send it off for a fungal culture or something. If you're not comfortable scraping and don't have a microscope on, in your office, you could just scrape it and send it for fungal culture. But it's going to be negative because it's a pityriasis alba. Cheeks and upper arms of darker skinned kids with eczema. That's where you see this most commonly. Contrast that with this. This is scaly. It's itchy. It has these kind of grouped colonies, and it's in hair-bearing areas that produce sebaceous materials. So anytime you see a distribution that likes oily areas or sebaceous materials, especially when they look like little colonies, just imagine this is like a little petri dish, and you have these little oval colonies that are all grouped together. This is tinea versicolor. So all of that adds up to a fungal issue. And this is an example where if you do scrape it, and you put KOH and put it under a microscope slide, this is one I did, you can see they used to call it like spaghetti and meatballs or like penne and meatballs, where you see the branching hyphae and then you see the corresponding little like meatball eggs of the fungus that are like the new ones that are growing. So that's probably not the correct term for it, but they call it penne and meatballs here, spaghetti and meatballs. But you don't need to do that. You can just look at this and say, this is in the sebaceous distribution. It has these little grouped colonies together. It's scaly, it's slightly itchy. This doesn't fit that profile of P. alba. This is all in the distribution of where fungus likes to feed on oily stuff. All right, so those are some things that are adjacent to eczema or things that are mimics of things that are adjacent to eczema, discolorations, different infection things that like when your skin barrier is broken down, etc. Now we're going to look at some diseases that are really itchy and diseases from scratching. So here is a patch of it's a hyperpigmented, intensely pruritic or burning patch over the left scapula here. So what do you notice about this distribution? I don't know if you guys have your mics on or not, but this is more common than you think if you see a distribution like this. This isn't a dermatomal distribution. You'll notice this does not cross to the other side of her spine. And it's in a dermatomal distribution. So when you see these brownish areas, especially when they're a dermatome, think about the wiring of your body, think about nerves, and say if a wire blew behind my wall, it would like fry my wall and create this like brown, burnt looking area. That's exactly what this looks like to me. So it's like you need an electrician for this. This is a neurologist, and this is called notalgia paresthetica. So you get pruritus due to nerve entrapment, usually from T2 to T6. But you can get this anywhere where nerves exit the spine. And an interesting treatment, yes, you can use topical steroids, but the one that usually we use is topical capsaicin. Capsaicin is the active ingredient in hot peppers, and it basically causes the nerves to fire and waste their neurotransmitters, and you can essentially burn this thing out. You can also do Neurontin if you're a neurologist or if you're comfortable prescribing Neurontin. But the point is you have to use something that targets the nerves underneath. Just treating the skin is not going to make this person better. Giving them antihistamines is silly. Giving them dupilumab or omalizumab is silly. It's a nerve problem. Here's one from chronic scratching. So this could have started out life as an atopic or a bad hand eczema patient or an allergic contact patient, but now they're scratching and rubbing at their skin and it gets lichenified. So you can see this is an example of lichenification where it's really thick. So this is an erythematous lichenified excoriated plaque, on the thenar eminence of the thumb or wherever. And this is called lichen simplex chronicus. So what you need to do here is get the person to stop scratching. How do I do that? Number one, you want to cover this so they can't access it easily. Number two, I want to give them a keratolytic, right? Because I showed you those cells at the top are all dead. They don't have nuclei. So what do steroids do? Steroids act on the nuclei to reduce the transcription of inflammatory cytokines. Well, is my steroid going to work if it's acting superficially on dead skin cells that don't have nuclei? Probably not, right? So what do you actually want to do? You want to apply a keratolytic to break down all that dead epidermis on top here, something like 40% urea cream or urea lotion. Let that sit on it after they get out of the bath or shower. Then denude off all that dead skin with like a pumice stone or something. Now I can actually get to live skin cells with my steroid. Then you hit them with a clobetasol, cover it, wrap it, do whatever you can so they're not continuing to rub and scratch at it. Do that for 2 weeks and this person will feel like a new human being. So you want to first break down the dead skin cells. If you put an active ingredient on something that has a shield of dead skin cells, you're just wasting your money, wasting your time. Prurigo nodularis, now we actually have good treatments for this. So we have biologic treatments like nemolizumab that targets IL-31 or dupilumab that targets IL-4 and IL-13. But the point here is this is someone who's chronically picking at their skin, and that could have started out life as an atopic disease. It could have also started out life as a psychiatric disease, like a veteran who comes back from war as PTSD is picking all over his skin. Just remember, they're picking at their skin. Your immune system doesn't ignore the fact that the organism that it serves is doing that. It says, the organism I serve, I'm the immune system for this person, they are picking at their skin. They're telling me there's something on their skin that needs removal, and they keep picking, so it's not working. So I need to turn on an inflammatory pathway that involves the Th2 cell differentiation pathway to help flush their body of whatever it is that's invading it. Maybe that's a bug, maybe that's a parasite. Who knows? I just know they need help picking it off. So they start activating IL-4, IL-13, IL-31. So these are not just the result of the problem. They are the cause of the problem. Those are filled with inflammatory markers and other inflammatory magnets for inflammation, like periostin, for example, where it's causing all those inflammatory cells to come to this area. It's opening up vascular channels to make that easier for that to happen. So by targeting the immune responses for this, you're actually able to melt these things away. Whereas if those were just like keloid scars, like I performed surgery on the chest for someone who has a skin cancer on their chest, that's a keloid. Like I'm not going to treat that with dupilumab or nemolizumab or whatever. But these are filled with inflammatory things. They're not just keloid scars with fibrosis. So you can actually treat them with immune targets, which is actually pretty. It makes it much easier to treat and pretty cool. Here's the extreme example of a veteran who came back from war who had neurotic excoriations and was picking. That yellow stuff is subcutaneous fat. So he's been picking down to his fat due to a psychiatric disorder. You can see all the hypopigmentation here, but I would want to check the rest of him and make sure this is happening other places, because if this was just isolated to a dermatome, what are we going to say? What's happening with the nerve underneath? And then I want to do some studies to look at what's happening with the nerve underneath. But this guy was PTSD and picking many different areas and was down to his fat. Here's a mimic of a pruritic disorder that can easily mimic eczema. This is the number one mimic I think about when someone has eczema. These are erythematous, eczematous looking papules that are coalesced into plaques, but the distribution on the dorsal hands, abdomen, and groin make me concerned, because this is not a typical distribution for eczema. I'm going to check the webbing of the fingers. I'm going to ask if this eczema is actually transmissible to other family members, because eczema should not be contagious. And they're going to tell me, yeah, other family members are itchy too. And this is scabies, okay? So scabies look like eczema because the mites that get into the skin, your skin starts reacting to the fact that the mites are there and the feces of the mites, and it starts creating what looks like eczematous rashes. But the distribution is wrong, it's pruritic, and it should not be transmissible. If you're having trouble treating someone's eczema and it's involving the hands or certainly the groin or the abdomen, I have a very low threshold to provide them a dose of ivermectin. It's a one-time oral dose. It's easy to do. It has virtually no side effects, and it will clear scabies the vast majority of the time. You just give it to the entire family. So there are times where I was struggling. I tried to scrape them to look for scabies under the microscope. I couldn't find it because it's hard to get an actual scabies mite under the microscope. And I just said, you know what? We're just going to treat it and rule it out as a cause. And you treat it, and the eczema magically goes away. So you're going to miss this. Like, you're going to diagnose people with eczema that actually have scabies. Just have it on your radar. Have a low threshold to also treat scabies if it looks like it's in a distribution that makes sense. If you're good at scraping it, or you get lucky, then you get under the microscope that looks like this, and that's the actual little scabies mite. I think it looks like those horseshoe crabs, like on the beach, but they're alive. Like, you scrape them and they're under the microscope when they're swimming around in mineral oil that you prepped it with, and it's kind of disconcerting. So that's one that I actually did from a kid at the Children's Hospital in my derm residency. All right, so we talked about this, but it's nothing more than a type 4 hypersensitivity reaction to the mites. So therefore, you're going to get an eczematous-looking rash. So don't get fooled. Have that on your differential. This is the treatment. I like the oral option because it's easy. You can do a topical option, especially if you know it's scabies, and you got to treat the whole family. Okay, here's some diseases you can mistake for eczema, especially facial things, because facial things, there's a lot more differentials. So here is, I call this a combination of acne and eczema. So you see these little, acneiform papules, but it's on a base of an erythematous eczematous rash, or I should say erythematous eczematous plaques, and it's hugging right up against the nasal ala. If you see this hugging up against the nasal ala, you're done. You know what the diagnosis is. You don't have to go any further. It also loves around the mouth and chin. It also loves around the eyes. And the name of the diagnosis tells you that because this is perioral dermatitis or periorofacial dermatitis. And it also loves around the eyes here. So you could see acne on eczema, right? See that? Acne on eczema, acne on eczema. That's periorofacial dermatitis. During the pandemic, everybody was calling this maskne. People were wearing the masks, and they would get stuff like this from wearing the masks. Steroids can worsen it. So if you give someone hydrocortisone or something stronger as a steroid, there's a good chance you're going to either do this to someone or worsen what they already have, or at least not make them fully better. And the treatment that I like is actually oral tetracycline antibiotics, the same ones we use for acne. They're also anti-inflammatory. For an adult, I do doxycycline, 100 milligrams twice per day. Look at this, for 1 to 2 months. This is not something you do for like a week and it gets better. Just like we do for acne, 100 milligrams twice a day for 1 to 2 months. I tell them doxy can make you more sun sensitive, so you can burn easier, and it can cause some reflux or heartburn. You can also do topicals, which will treat this about 50% of the time, and the other 50% the person won't get much better, and you'll have to do the oral. So I usually just do the oral to start with. Another facial rash not to be missed and not to be confused with the impetigo I showed you earlier. This is erythematous, right? Somewhat eczematous plaques with yellowish greasy scale, and it's in a seborrheic distribution. It's liking around the scalp. It's liking around the eyebrows. It loves around the nasolabial folds where you produce tons of oil, because this has a fungal component to it and an inflammatory component to it. And some patients are just genetically predisposed. So this is seborrheic dermatitis. You could see it as cradle cap in infants, but it can affect all ages. And it's an inflammatory response to the normally appearing Malassezia yeast that is on the skin. It's diagnosed clinically. You can treat it with topical antifungals plus a topical steroid, or there's now monotherapy that's FDA approved for this. This monotherapy is also FDA approved for atopic derm in the 0.15% cream, which is topical roflumilast. I won't mention brand names here for the sake of CME, but it starts with a Z. And this is for seborrheic dermatitis. It also comes in a foam, so you can use it on the scalp. You can use it on the face, and the foam will just nicely dissolve and melt away into the rash. And you don't have to use two things like a steroid and antifungal. You can just use this one thing. It's also approved for eczema. It's also approved for psoriasis. Contrast that facial rash with this one, which is erythema. There are some papules involved here. So this is one where you could call it maculopapular, even though I hate that term, and I'll explain to you why I never use it, because macules are flat and papules are not flat. So I prefer you say these are erythematous papules on a base of erythematous patches. And this occurs on the face of a girl. It's in a photo distributed area, so it's on her face. And the history would be that she gets this when they take their spring break trip to Florida or something, and when she gets her first sun exposure. So this is called polymorphous light eruption, PMLE. Usually in the first 3 decades of life, usually in the spring and summer when they get their first light exposures, it tends to be the same time every year, the same rash every year. So we usually diagnose this like the second or third year it happens. It's monomorphic for a given patient. I mean, it looks the same for them, but it's polymorphous in the sense that every patient kind of has their own unique look to it. But it's in a photo-distributed area, and it is usually in the same place and same time of year. Contrast these other facial rashes with these erythematous dermal plaques. Why do I say dermal? Look how juicy that is. That's not just superficial on the skin. That's got some heft to it. It goes down to the dermal layers of the skin. You do have this overlying, white or almost silvery scale. So you might say, well, that sounds like psoriasis to me. But then you look at the distribution, and it's in a very photo-distributed distribution that looks like what? This looks like an ink blot butterfly, right? So this is the butterfly rash of lupus. And why is it in a butterfly distribution? Because these are the prominent areas that stick out on your face that get the most sun. And it's dermal because this autoimmune disorder, that when it affects the skin, autoimmune disorders tend to affect the deeper layers of the skin. This is an example of a rare thing where a shave biopsy might not be enough, where like getting a punch and going down to the dermis is what you need, because you need to look at the blood vessels and dermal layers of the skin. But this is the rash of lupus on the face, so I show it to you because this is the facial rash that you could potentially see. Now let's look at some rashes that mimic circular rashes. These are usually on the body. And the classic one that you're going to see a lot, that you're going to be responsible for diagnosing, is nummular dermatitis or coin-shaped eczema. So I think nummulus meant like discs or coins in Latin. So this is nummular dermatitis. What you'll notice here is that it looks like an eczematous rash or an eczematous plaque. It could be filled, it's usually filled in here, and it could be pretty angry and red from the person scratching, but it should be pretty filled in. It can maybe be a little lighter in the center, but it should not be like a ring. It should have some filling in here. And this is pretty typical of nummular dermatitis or discoid eczema, coin-shaped eczema. It's frequently confused with ringworm, and I'll show you the difference. And you can scrape it to determine if it's fungus or not, but if it's filled in and it doesn't have a leading edge of scale, then that's more commonly in nummular dermatitis, usually in older people, usually in dry climates, but not always, and you would treat it with a topical steroid. Here's another circular-looking rash. This is a dusky, brownish, discolored rash on the tip of the penis. I put it on the tip of the penis intentionally because this is the classic distribution for this. And the person might tell you that they recently took an antibiotic, or maybe that they recently pulled a muscle and started taking something like ibuprofen or naproxen or something like that. This is fixed drug eruption. It is fixed because it's usually in the same place, and it's usually from the same drug. And basically, you figure this out from history, or if you want to be a sadist, you can have them retake the drug and they'll get it in the same place. But a lot of times they're embarrassed because it's on the penis. They won't always tell you that. If you see rashes on the penis, think about scabies, think about psoriasis, but also think, did you just take something in the last, several days or week? Usually it's even quicker than that, 30 minutes to 8 hours. Usually it resolves within a week. And see if you can get some history on fixed drug, and here are some examples for fixed drug. You can also get post-inflammatory hyperpigmentation with a lot of different rashes. So this is where I call this the paw print of where the animal used to be. So Mark, what was this rash? I have no idea. I know it was circular. Could have been psoriasis, could have been fixed drug, could have been nummular, could have been something else. But there's a circular area here of hyperpigmentation of whatever inflammation was there. It revved up their melanocytes, and now they have a paw print there that's going to probably take 6 months to a year to go away. And that's just the way it works. You can also get hypopigmentation. This you can give things like bleaching creams like hydroquinone, which can help, or you can laser this if you wanted to for cosmetic reasons. For hypopigmentation from post-inflammatory, there's almost nothing to do. It's just like pityriasis alba. You just tell the patient, this is what it is. I can't fix it, but it's going to eventually go away on its own. And contrast this with tinea corporis. So versus nummular derm, which was circular but filled in. This is circular but not filled in. It has those little satellite lesions, those little colonies, and there's a clear central area of clearing, and you would see some scale. So where you'd want to scrape if you were going to do a culture would be the rim of scale here. This is where the fungus is pushing out and growing. The center is where it used to be. Scraping or biopsying that's pretty useless. Scraping or biopsying the leading edge is where you want to be. So there's other dermatophyte infections, not just the body, but also the feet, the hands, the scalp. They have different names, and there's different dermatophytes. But again, what you look at is for branching hyphae and fungal elements under the microscope. If you give someone who has a fungus clobetasol or a strong topical steroid, you will do this to them. It will drive the fungus deeper down. It will get this shiny purplish appearance, and now you have what's called a Meioki's granuloma. And instead of giving them topical antifungals for 2 weeks, you're going to give them 4 to 6 weeks of oral antifungal therapy and be much harder to treat. So if I'm not sure if it's a fungus or it's nummular, yes, you could scrape it. If you're not comfortable scraping it, you could send it for culture. Nummular dermatitis, no harm, no foul. You're not going to make them better, or you might give them a bit of an emollient effect and moisturize them. But if you give someone a steroid and it's actually a fungus, you're going to do this to them. So if it looks like ringworm, treat ringworm. If it looks like nummular, treat nummular. If you're not 100% sure, treat fungus first, because you're not going to harm someone and do this. And that's why we hate the topical mixed creams where it's like, let's give them a fungus and a steroid. It's like, number one, then you don't know what you're doing diagnostically, and you could still give them a Meioki's granuloma. Contrast all of that with something that is still a ring. You could definitely think that this is a ringworm, but notice that this is raised up here and it's dermal and it's flesh colored. Dermal, again, deeper. Usually that means autoimmune inflammatory, not something superficial like a fungus. And this is the classic distribution on the dorsal hand. So this is called granuloma annulare. So it's annular, it's circular. It has these granulomas, these dermal components to it. There's still central clearing, but there's no leading edge here. There's no scaling. It's just dermal papules in a circular collection, and you can definitely have more than one of these all over. And this would be something you refer to a dermatologist for treatment for, because you can do things like injections, like I did here, where you can inject outside of it and get inject triamcinolone steroid injection, or you can do something like a TNF inhibitor. But the point is, you should know that this exists because you can confuse it with other things. This is granuloma annulare. And then the last thing is, this is on the dorsal hand. It's circular, it's erythematous, it's yellowish crusted, and this is in a guy who probably has a lot of sun damage. It's growing, maybe it's bleeding, and this is a squamous cell. So you don't want to miss a squamous cell. Oh, maybe that's nummular dermatitis, maybe that's psoriasis. Well, it's on the sun-exposed areas of a 70-year-old who's had a history of other skin cancers, and you can see it has this kind of shiny appearance. It's doubled in size. It has yellowish crusting in it, and it's on an area that's gotten a lot of sun. Let's make sure this isn't a skin cancer. It's acting aggressively. Here's an example of psoriasis, yellow salmon-colored plaques with overlying white or silvery scale. Notice the nail changes. So if you're not sure if something's psoriasis or eczema, check their nails. I'm going to skip ahead here for the sake of time, but here's the distribution for psoriasis. Here is teardrop shapes. You can get guttate psoriasis. You can get inverse psoriasis. Inverse distribution means your private areas, basically. So axillary, groin, inframammary. You could think this was yeast. You could think this was, some kind of contact thing. Inverse distributions of things. So that still looks like a psoriasis plaque. Don't get confused. If it's symmetric and bilateral, that's more likely an autoimmune inflammatory process than it is some kind of weird allergic contact. So if you see an inverse distribution, don't get confused. This is not the underwire for bra. This is not yeast. This is inverse psoriasis. Okay, here's some ones not to be missed. Targetoid lesions in a young adult. Erythema multiforme, kind of like the first rung on the ladder of the spectrum of SJS and TEN. Usually resolves within 2 weeks. The common mistake is giving it steroids. What you need is to treat HSV. So erythema multiforme, when you see these targetoid lesions on the palms, ask yourself, do they have a cold sore? If you see it, treat it. If you don't see it, still treat it, because most of the time it's going to be from an HSV lesion that was there, that's bubbling, and it's about to happen. And there's no other treatment for the other triggers for it. So there's other viruses that cause it. There's medications that cause it, but none of those have treatments other than removing the cause. HSV is the thing you can actually treat and get it better faster. Do not give oral steroids if you think it's erythema multiforme. And remember, erythema multiforme has the targetoid lesions, and then major erythema multiforme major has the mucosal lesions, like on the mouth. So you could see a bad looking mouth like this, but this person has more than that. They have these bullae, these dusky areas. They have a lot of erythema here, and they're about to have bulle and peeling and stuff like that. If you see bad eyes, bad lips, and these bulle and peeling, bad news. Get them immediately admitted to a burn unit in the hospital because they have SJS or TEN, and if you don't intervene, they could have up to a 50% mortality. So hopefully you're familiar with these things like Nikolsky sign. The worst mucosal involvement you ever see in your career for allergy and derm is SJS, TEN. Don't get confused. You can get urogenital, you can get mouth, you can get eyes. Calculate a score 10s. You can do this stuff to try to predict, what their prognostic mortality rate is. These are some of the causes. Burn some of these things into your brain, especially barbiturates, carbamazepine, lamotrigine, sulfa-based things. If you see any of those on a med list and they're coming in with rashes or mucosal things, SJS, TEN until proven otherwise. Yes, there are infections, but these a lot of times are red herrings because they had some upper respiratory infection and they're like, oh yeah, it's probably mycoplasma, but they're taking NSAIDs because they have a fever and they're taking ibuprofen. It could be the ibuprofen or the Tylenol or whatever they're taking. Stop everything. I don't care if you think it's mycoplasma and you're checking them for that. Stop everything on their med list unless they're going to die if they don't take that thing. They don't need Tylenol, ibuprofen for fever. Don't let some resident write that in the chart. Stop everything because you don't know what it is, but you know that they're going to die if you get it wrong. So just stop everything. Ibuprofen, Tylenol, all that stuff. Just stop it. Okay, gold standard, withdraw the offending agent. And I advocate for this, TNF inhibitors. If I ever roll up to the Children's Mercy Hospital ER and somehow I'm getting admitted there, even though I'm an adult, or the Truman ER, God forbid, then give me a TNF inhibitor first and ask questions later, okay? Yes, IVIG, maybe not steroids if pulmonary, whoever wants them. Absolutely TNF inhibitor. There's a lot of good data now that it prevents mortality and morbidity, especially mortality, even in patients that have a bad score 10. Okay, another one not to be missed is CTCL. So these are well-defined erythematous plaques. The tip-off here, look how well-defined these things are, and they're in the bathing suit distribution, and they also spare the face. So light helps this. We do phototherapy for the earliest forms of this. So we do light therapy, but you want to look for eczema that's not responding to typical treatment. You give it Dupixent and it laughs at you, or you give it topical steroids and it laughs at you. And it's in the bathing suit distribution and it doesn't seem to be affecting the face, or maybe they have some lymph node enlargement. CTCL, biopsy it, send it to someone who knows how to look for CTCL biopsies, like an academic center, and then get them to a specialist. It can also just be erythrodermic. CTCL under the microscope looks like too many for too little. Look at all these lymphocytes here. They're all just little purple cells with lots of nuclei and not much else going on. But where's all the inflammation? Like, why are they all here? Where's the bacteria? Where's the inflammation? What are they responding to? They're not responding to anything. They're all monoclonal. They're the same exact lymphocyte because it's CTCL. It's a lymphoma. And you can get these little Potrier sterile microabscesses where they don't actually have, there's no bacteria in there. They're not responding to anything, just a collection of cells. Dermatomal distribution for zoster, don't miss that. If they say they're having itching or stinging or pain or electrical feelings in a dermatomal distribution, don't wait for the rash, just start treating them. They might just say, hey, I have a lot of itching, but they're in a dermatomal distribution. And then I want to show you an example of what could present as urticaria to you. So this could present as just urticaria looking stuff. It's really itchy and it looks like hives, but maybe it's in a 65-year-old patient. Why should they just randomly get CSU? That's a 20 to 40-year-old person, female disease. This is a 70-year-old male. Why? Maybe they have bullous pemphigoid and they're going to start developing bullae after you treat them, for their urticaria and they don't get better for 3 months. But dupilumab treats both bullous pemphigoid and CSU. So if you weren't sure and you gave them dupilumab, they might get better anyway. But if it's a 60, 70-year-old, start asking yourself, what medications are you taking? Because maybe it's medication related. And why is this not bullous pemphigoid? This would be an example where you'd biopsy it and look for immunofluorescence, which I'm showing you a nice example of here. And you're looking for the antibodies against BP280 and 230. Sorry, BP180 and 230. That's creating this cleavage site along the epidermis here. So why do I highlight these? Another board fodder. They always love asking about bullous pemphigoid and what are the antigens against. So there you go. And then lastly, if you just see a gentleman who is older, 50s, 60s, not just a gentleman, but anybody. And they have these little isolated, pink scaly papules on their face. Don't get creative with this. These are really common. And this is just all sun damage. This is what goes into skin cancers eventually. So these are actinic keratoses, just little pink scaly papules. Loves the face, loves the forearms, love places that gets a lot of sun. And we can treat that with freezing them and other therapies with the dermatologist. But don't get confused and think this is some form of eczema, some form of inflammatory rash. These are just isolated little pink scaly things that are really common in older people that we want to destroy so they don't turn into a skin cancer. And lastly, a word on topical steroids. The fear is they cause atrophy, telangiectasias, and stria, right? So like overuse of steroids. My rule, which like I've named for myself because I want to live on, when I die, like the Serota rule is what this is, because this is my theory. You can't go from disease to damage. You have to go from disease to normal. You have to pass go. And then if you keep putting steroids on, then you do that. So nummular dermatitis, put the steroid on. Don't make sure you color in the lines here. It's going to do that. And then don't do that. Don't keep putting it on. Don't use it as your moisturizer. Stop and make sure you color in the lines so you don't get this atrophy and stria. So steroids don't damage disease skin, they damage normal skin. That being said, we have some really good non-steroidals these days where we really don't need steroids for much anymore, especially for bread and butter things like eczema and psoriasis. There's other good non-steroidals that are safer, that don't do this, and are pretty strong. But if you want to use steroids, here's what I use. Desnide, something weak for the face. Medium level, like these two, for the body. Clobetasol for the tough area.